how we can manage elevated intracranial pressure. Um, we will talk about specific pathologies in head injury patients. So what it can be. So we have, if you think about the head, we have the scalp, we have the skull, we have the dura, we have the brain, and then we have the ventricles. If we talk about the scalp, we can get certain hematomas due or injuries. So you can get cut wound in the scalp, which can bleed and cause hypovolemia, and patients with scalp lacerations can have hypovolemic shock only from a scalp laceration. So please, whenever you get a patient with a scalp laceration, suture it as soon as possible. Don't just do it a pressure on it, because as long as they bleed, they may go into hypovolemic shock. Some of these are specific to certain age groups, like carboxyxidinium, which happens in neonates. If you know the vacuum delivery, okay, when they suck the head of the baby, they will have a bleeding under their skin. Sometimes in young age group, when they fall, they will have a subperiosteal hematomas or subgaleal hematomas. Why are these important? They are not important much in an adult who gets a fall and he developed a small subperiosteal hematoma or subgaleal hematoma. These are important in infant and toddlers and the young patients because they can lose a significant amount of their circulating blood in the subgaleal spaces. The subperiosteal, because it is limited and it becomes hard and it is contained, it is less likely to cause a problem. But with subgaleal hematomas, you get a child, a toddler, an infant who fell and he has a subgaleal hematoma, please make sure you admit him. You get a serial hemoglobins to say if there is a drop in their hemoglobin, and to make sure that they are well resuscitated. Don't just discharge them from the ER. It is a serious issue, and unfortunately, we have few events, couple of kids who passed away actually in Jordan because of mismanagement in the ER of subgaleal hematomas, and this is only in the last 2 years. Then we have the skull. We have skull fractures. We have the linear skull fracture, which is does not, which is you know what is the linear. It is just a crack on the skull. Okay, it is not displaced fracture. It is not a free part of the bone moving in out, and it is not displaced. And usually these have no significance unless they are associated with another pathology like underlying subdural hematoma or extradural hematoma. But because they don't happen in a spontaneous fashion or on a low velocity accident, see, they usually high velocity accidents or high impact trauma, the linear skull fracture needs to be taken seriously in case the patient developed underlying pathology or a problem like extradural subdural hematoma. The second type of skull fracture is the breast skull fracture. And this is when we will see images for these. I'm just talking about the generalities. The breast skull fracture is when there's displacement of the cortex of the bone to the inside of the skull. And then we have a special entity for the skull base fractures, which most of the time is linear fracture, but they can cause different problems than the linear skull fractures in the vault. Then we have the concussion, and we have the diffuse axonal injury, and we are coming to discuss these. So basically, this is what you can get from. There's a slide about hemorrhage. Yes, this is the slide about the hemorrhage. When you get brain hemorrhage, it can be extradural/epidural. It is the same. Subdural, subarachnoid hemorrhage, contusions, intracerebral hemorrhage, or intraventricular hemorrhage. So to say what types of trauma or problems that you can get, the ones that can get into the skull, subgaleal hematoma, subperiosteal hematoma, and carboxyxidinium. If you ask about the skull, you can get a linear skull fracture, you can get a dead breast skull fracture, or a skull base fracture. The type of intracranial hemorrhage can be extradural, subdural, subarachnoid, contusions, intracerebral hemorrhage, or intraventricular hemorrhage. And lastly, we have two specific entities, the brain concussion and the diffuse axonal injury. And this is mainly all the pathologies you can get from trauma in the brain and the skull. So I'm not aware of any other entities. So, how the injury can be? It can be closed or penetrating head injury. The closed head injury is the most common. We see it in the motor vehicle accident. We see it in sports and assaults and industrial and workplace due to falls. In a blast injury when لما يكون في uh, انفجار أو شيء الwaves of the ultrasonic the waves can cause acceleration and deceleration and cause injuries. And we have non-accidental injury like what happens in children. Penetrating injury, gunshots, and stabbing. And yes, you can get people who had the knife penetrated their skulls or say hadid, metal that went directly through the skull and caused problems. How we classify them, it depends on the Glasgow-Coma scale. And if it is mild traumatic brain injury, the Glasgow-Coma scale will be 14 to 15. If it is moderate, it will be 9 to 13. And in severe, it is 3 to 8. And I hope that you are familiar with the Glasgow-Coma scale. If not, please familiarize yourself with the Glasgow-Coma scale. It is the cornerstone of assessing patient and making clinical decision. It has three components. Eye-opening, is it spontaneous? It is to speech or to sound. It is to pain or pressure or no eye-opening. Verbal responses, is the patient oriented to time, place, and person, or he's confused. He can speak, but he's not aware about his surrounding. He cannot identify persons, time of the day, etc. If he's too unwell and he keeps saying just words that intermittent, then he gets a 3 point. If he just mumbles some sound, then he gets a 2 points. And if there is no response, he gets only 1 point. In the motor response, if he has purposeful movement, like trying to catch or move, this is a 6, and he obeys command, this is a 6. If he localized, if you cause a pain in the upper chest and he pull your hand away, this is localization. If he flexes his hand trying to reach where is the source of the pain, this is normal flexion, and this is 4. Abnormal flexion, he won't able to reach. And then we have extended or decourse decerebrate posture, and this will take 2. And this is very important that you familiarize yourself with the Glasgow-Coma scale. It is the cornerstone for neurosurgical trauma. Now, we will start with this, and this is a normal CT scan, okay? And if you can see, I wanted to start with the normal CT scan so we can say another one, which is abnormal CT scan. So this is an axial cut of a CT scan, non-enhanced, so there's no contrast, and this is a soft tissue window or a brain window compared to what we get as a bone window, which shows us the bone better than the brain tissue. This is a soft tissue or brain window. And if you look here, we have the lateral ventricle, we have septum pellucidum, we have calcification in the choroid plexus. And let me run this, please. Okay. So what I want you to see, if you look at these here, we have, there's the sulci and gyri on the surface of the brain. تعرفوا لحظة شوي بس أنا بدي أسأل سؤال قبل ما أكمل. كل واحد ممكن يحكي لي أي سنة هو في كلية الطب عشان ما أكونش بحكي وتكون الحكي بعيد، أو تكتبوا لي على الشات كل واحد بأي سنة. عمر سنة سادسة. لانا. محمد سنة سادسة، ممتاز. تغريد خامسة، ممتاز. بس هم انتوا هدول الموجودين وبعدين انا. اوكي طيب ماشي. يعني انتوا راح تفهموا علي، فيش داعي انه to simplify things ابسط. اوكي if we go up، تتذكروا احنا بنعرف انه في convolutions على البرين اللي بنسميهم السلساي والجيراي. اوكي in these sulci and gyri we do get CSF okay running in the subarachnoid spaces. If you look here, these are the sulci, and we can see the dark thing is the CSF surrounding the brain in the subarachnoid spaces. And these convolutions are called the sulci, and these one are the gyri. And this is CSF here. So why I'm showing this? Because when you have elevated intracranial pressure, because the pressure is very high, the CSF gets out of the skull and goes down to the spinal canal. And these spaces are obliterated because the brain is swollen and we have loss of the subarachnoid spaces cortically. The other thing that we see when there's elevated intracranial pressure is if you look at these, you can see that the hyperdense here is the cortex, and then we have the white matter. When there's a high ICP, there is a loss of differentiation between the white and gray matter. What else can happen? At the level of foramen of Monro, this is foramen of Monro, we measure something we call midline shift. So if we have a localized increase in the intracranial pressure on the right-hand side, it will push to the left side, and this is, we make a line from the crista galli down vertically, and we see how much foramen Monro has pushed to the other side, and this is what we call the distance of midline shift. If we go down, we have the suprasellar arachnoid space, and we have the sylvian fissure. Again, if there's a high ICP, these spaces will be obliterated. We have loss of the basal cisterns, which is also filled with CSF because of the elevated pressure. And lastly, another thing that we can see on the CT scan is also we can see this is slightly lower than foramen magnum. Let's try and get the foramen magnum. This is about the foramen magnum. Also, there is CSF around the spinal cord and the medulla oblongata. In severely elevated ICP, we will have loss of the CSF. So these are the signs of elevated intracranial pressure that we should see on a CT scan. Now, we have a 31 years old. He's a male patient with a gunshot to the head. His GCS is 6. Pupils are bilaterally dilated with a sluggish reaction to the light. Who's going to tell me? Who's going to tell me what he's going to do now?
We start by the first survey by checking the ABC.
You will start by the ABC first. Is
Yes.
there anything that you do أغلب طلابنا نفس الشيء بنسوا قبل ال ABC?
Vital signs.
الفيتال ساينز بتيجي مع حلانا تفضلي.
Safety first.
Safety first. Safe environment. Safe environment for you and for the patient, not only for the patient. This is very important. We all want to do our best to the patient. Sometimes we sacrifice ourselves for the patient, but should not be the case. Okay, we have to take care of ourselves and then take care of the patient. And I'm aware of 1 or 2 incidents, at least, where people stop to help and they get hit by a moving car. Okay, because they did not take safety precautions. I can tell you عن مريضين عندنا بالطابق في مستشفى الأمير حمزة على مدى 5 سنين الماضيات. They developed seizure and nobody cared about the safety of the patient. They tried just to get a cannula in to give anti-epileptic medication, and both patients fell from the bed. Okay, and when one of them fell and he broke his neck. So safety for the patient. Patient with a traumatic brain injury can develop seizure. Patient with a traumatic brain injury are unconscious. They may be confused. They will try to get out of the bed. They are not stable on their feet, so they may fall. So this is the precautions. Simple. Just raise the rails of the bed so you prevent patients from falling down from the bed if they develop seizure. Keep your eye on them and then start your ABC. Then start your primary surveillance. Okay. I know أغلبنا بنعتقد وأنا زيكم كنت أعتقد this is by default. شو بتحكي أنت؟ ليش بتحكي لي هاي الجملة وأنا طالب؟ Actually, we forget most of the time to do this. Okay. So always safe environment, please. Okay. نرجع للسلايدات. So the first thing that we will do is safe environment, and then we will do the ABC. This is right. So primary survey, we will do the airways, breathing, circulation, disability, and exposure. And please, exposure in a trauma patient and in general is important. You have to examine your patient thoroughly, especially unconscious patients, especially patients who cannot communicate. You don't know where is the other injury that is killing him. Okay. Um, Sometimes a minor bleed from a back wound or a stab or a bullet in the back is missed because you are not exposing the whole body. I know we have cultural issues about the exposure, but if we do it with dignity, okay, nobody will object on this. So please do a full exposure of the patients. بعد هيك شو بدكم تسووا؟ So in our primary survey, airways are intact and clear. We did suctioning, but we put the patient, we did intubate the patient because his Glasgow Coma scale is 6. Circulation is fine, blood pressure is fine. What you are going to do next? Oh,
A non-contrast head CT scan.
patient is stable, so I can get him to the CT scan. I did a CT scan with no contrast. Why with no contrast? Why we are not doing contrast?
Because you can make thing contrast with fluid. Because
Because
you're
what?
looking for hemorrhage. You're looking to differentiate between is hemorrhage or not.
Mm-hmm.
So if you give contrast, you can see the fluid.
It's because you don't need it. Yani, if we give the contrast either to see the blood vessels, صح? Or to have a lesion that is enhancing. If it is a bleeding, it is by default hyper dense. I don't need it to enhance. Sometimes we do CT angiograms for patients with trauma to rule out dissections, but it is not the ideal. طب ليش ما اسوي MRI scan؟ بيعطيني more details. شو رايك يا عمر؟
Because it's time consuming. Because
It
it's
is
need more
time
time.
consuming. It is time consuming in a patient who's probably unstable, um, with who may deteriorate at any minute. Okay, and you cannot clog your ER with patients waiting for MRI scans. CT scan is quick, give you much more information, and it is better for bone assessment, which can be broken also in patient with head injury. So when we compare this to pediatric, in some centers around the world, they start to do MRI scan for trauma for pediatric age group below 6 years old. And they do MRI scan T2 sequence only, okay, which is slightly equivalent to doing a CT scan. They don't do a long MRI scan, just T2 sequence, and this will give you a pretty good information. And this is to avoid exposure, radiation exposure for pediatric age group below 6 years. And I don't think that is happening in lots of places, but pediatric hospitals, pediatric surgical hospitals like Great Ormond Street in London, they've been doing this for years now. And I think they are doing a good job with interpretation of T2 images as a CT scan, as they do with a CT scan. نرجع للpresentation. So you are right. You get this CT scan, and this is what you get. Who would like to describe the CT scan?
It's obviously a penetrating injury. His skull fracture, the temporal region, left.
Okay.
Uh,
Which one you think is the inlet and which one you think the outlet? I'll just run it again from the beginning. Sorry.
it's the inlet is from right.
The inlet from the right. Why you are saying it is from the right?
Well, as in forensic, there's the outlet is more aggressive.
You are right. The fracture usually is worse on the contralateral side or on the outlet side compared to the right hand side. Okay, what else? Who is going to describe this CT scan to me? It's been running now a few times. I'll keep it running. But I بدي أسمع صوت حدا يحكي لي يوصف السي تي سكان.
There is fluid in the basal ganglia.
Fluid
I
in the
think.
basal ganglia. Okay, let's go to the basal ganglia level. So I think it's hard from the artifact to see the basal ganglia. It's around there. It should be around there, the basal ganglia. So I don't think if you are talking about this dark thing here, this is not fluid.
Yeah.
This is pneumocephalus, or air inside the skull.
I see broken bones.
We have a broken frontoparietal bone on the left-hand side. We see a track of the bullet with intracerebral hemorrhage. What is these dots here? The black dots. These are pneumoceles. This is air inside the skull. We have some subarachnoid hemorrhage. If we go to the cisterns, this is the area of the basal cisterns. This is what we call the sylvian fissure. And we have thin layer of blood within the sylvian fissure and the basal cisterns. And this is a subarachnoid hemorrhage. Again, this is pneumocephalus or pneumoceles scatter. But what are the signs of elevated intracranial pressure that you can see? Let's go there. Stop here. Here. أو ولا قطع شوي يمكن.
Difficult to differentiate between
Sulci and gyri. There is what we call effacement of the sulci and gyri. They lost the shape. There is no CSF in between them. So we have effacement of the sulci and gyri, and this is a sign of elevated intracranial pressure. This is one. What else? What else you cannot differentiate from each other? I know it's probably the artifact causing this problem. هنا الأمور أوضح شوي بس there's no differentiation between white and the gray matter. Okay, and this loss of differentiation also reflects the possibility of elevated intracranial pressure. The obliteration of the basal cisterns that we've seen with the blood is again another clue that this patient has elevated intracranial pressure. The clinical assessment that he has a GCS of 6 is also indicative of elevated intracranial pressure. So I did my ABC, I did a CT scan, and this is the findings. What are we going to do next?
I'm gonna manage the ICB, high ICB.
Okay, how would you manage it?
I'll put the patient in a semi-sitting position.
Semi-sitting position, it usually comes with another word. دائما معاها كلمة ثانية.
I abstain from coughing or give
مريض
again.
على well done. خلينا ناخذهم واحدة واحدة. أول شيء ما بنحطه semi sitting اللي بنقصده إنه head elevated 30 degrees. بس تذكر إنه you need the neck neutral position. لأنه if the neck is not neutral and the head is turned to one side, okay, you are closing the jugular vein. And once you are closing the jugular vein in one side, it could be the dominant side, you are squeezing blood inside or preventing blood from coming out of the skull, and you are causing further congestion with the blood. And this means that the blood pressure will be elevated more and more. So when you say in each exam, whenever somebody asks you, or when you see a patient, head of bed elevated 30 degrees with head neutral and no compression on the neck. Is the neck collar is tight? Release it شوي. If the endotracheal tube is tied around the neck, just release it a bit, okay? Don't don't cause any compression on the neck. Don't close the jugulars. تمام? This is one. حكيت نقطة كتير كويسة. No coughing, no sneezing. Cuffing will elevate the intracranial pressure. So if the patient has intact gag reflex, they will try to cuff, okay, or they will have a gag reflex, and this will elevate the intracranial pressure. So I need to make sure that this patient is well sedated so they don't gag. They have muscle relaxants so they don't gag. That's right. What else?
I think we should ensure an euglycemic status of the patient
Why?
to prevent further brain damage from hyperglycemia or hypoglycemia.
It is proven that all patients with admission to ICU or ICU patient or patient in a critical situation, as long as it is imperative that you keep them euglycemic. Always hyperglycemia or hypoglycemia are associated with worse outcome. So yes, that's right. But let's keep it focused on the neurosurgery.
We may induce hyperventilation
Hyperventilation.
to decrease the carbon dioxide level. So
That's
to cause
correct.
vasoconstriction.
That's correct. The patient pupils are dilated and sluggish reaction, which means that this patient is possibly bending herniation, ankle herniation. Okay, so yes, I need a quick way of reducing the ICP, which is hyperventilation. But my question, what you mean by hyperventilation? How you will achieve it?
The patient is in
It should not, I think it should not exceed the PCO2 of 30 or something like that.
What is
No.
the normal BCO2?
35 to 45.
40
Perfect.
for a mean of 40.
Okay, 35 to 35, 45 is the acceptable range of the BCO2. If I want to cause hyperventilation, how much I will reduce the BCO2? To what extent?
To 30, I think.
So the
not-
agreement now is 32 to 35. Okay. هلا outside of the medicine خليني احكيكم something from our experience as doctors. اول ما بلشت neurosurgical residency we used to say hyperventilation bring the PCO2 from 25 to 28. This was the criteria and this was the guidelines. Later on they discovered that bringing it between 25 to 28 means that you cause severe vasoconstriction and this will result in a brain ischemia. So it has changed then to what they called normoventilation, but it is not actually normoventilation. Because we asked what we aim now is to bring the BCO2 between 32 and 35. We call it normoventilation rather hyperventilation to differentiate this from the old practice, what we used to do, okay? But it is still actually a hyperventilation. How you reduce the BCO2? If you have a patient intubated and you have the ventilator in front of you, okay, what are the settings that you have to change or to wash out CO2?
I will increase the minute ventilation, either by increasing the respiratory rate or the tidal volume.
So what
Respiratory rate.
What works well is playing with the respiratory rate. Increasing the respiratory rate will cause you to wash CO2. That's definitely right. Okay. So if you do it now, let's say we did get ABGs on this patient and his BCO2 is 40 and his respiratory rate is 12, I will put it up to 14, okay, or to 16 sometimes, and then check within 1 hour this 1 hour what we are doing in Jordan at the moment, but you should do it every 15 minutes, okay. ABGs again and check what is the ABGs and decide whether you need to go higher or actually lower your respiratory rate. Perfect. What else we can do?
I think there is some recommendation on giving prophylactic antiepileptic medications.
Definitely. Why?
To prevent seizure in the patient.
Why? خلي المريض يصير عنده seizure.
Because we're aiming to decrease the metabolic rate in the brain tissue.
That's definitely right. We want to, انا بحب بشبهها عشان ما تنسوها كيف بشبهها للطلاب. بحكيهم اذا المصروف ما بكفيك بدك تقتصد. كويس. وهذا نفس الشيء اذا انت you cannot deliver enough oxygen to the brain, okay, you have to save the brain from requiring more or demand more oxygen. Okay, so seizure, you need to give anti-epileptic, so prevent seizure. The second thing that you need to do is avoid hyperthermia or fever by giving antibiotics to these patients. The third thing, keep them fully sedated. Fully sedated. I cannot stress this enough. The more the patient is deeply sedated, no responses for painful stimuli, for fine stimulus, then the patient may get better response because you are reducing the requirements of the brain for oxygen. And in other terms, we call it the cerebral metabolic rate of O2. What else?
Corticosteroids.
Corticosteroids do not really work in a traumatic brain injury. All the studies now say they are associated with adverse effect rather than at least causing no harm. They are associated with adverse effect.
Mannitol may get benefit.
Mannitol, hypertonic saline. These are the osmotic. The mannitol is the osmotic diuretic, and it will cause a shift of the paracellular interstitial fluid from the extravascular spaces to the intravascular spaces, and this will reduce the amount of fluid within the brain. And similarly, by osmosis, hypertonic saline will bring the fluid from the interstitial spaces to the intravascular spaces. But what is the problem with mannitol? There's
It's a
a big
diuretic.
problem.
It causes dehydration.
One, and it lowers the blood pressure. And if we remember, the cerebral perfusion pressure is MAP, which is the mean arterial pressure, minus the ICP. So if I drop the blood pressure in a patient who has a critical cerebral perfusion pressure, okay, then I'm causing ischemia. This is one problem. The other problem that we found is that repeated doses of mannitol. Remember, these patients have dysfunctioning blood-brain barrier. So the blood-brain barrier is not working well, and it may be permeable, completely permeable. So with the repeated doses, each time we give a dose of mannitol, some of the mannitol will migrate to the interstitial spaces. And when it is in the interstitial spaces, it will accumulate. After the first 48 hours, if you give the mannitol for 48 hours or more, you will start giving the dose of the mannitol. The ICB will come down, but then within 1 hour, you will notice a spike again of the intracranial pressure. And the reason for this, that the accumulation of mannitol within the interstitial spaces. So when the dose starts, you have more in the intravascular compartment, and this is take the fluid out to the intravascular compartment. When the metabolites start to fall and the concentration in the blood start to fall, the mannitol, which has accumulated in the interstitial spaces, will start to draw fluid to the parenchyma of the brain, and this will cause worsening of the brain edema. So the new recommendations is you should not use it for more than 48 hours. I personally don't use it unless there's an emergency problem, like this patient have a sluggish reaction, or somebody with extradural hematoma that I'm preparing to take him to the theater and I need a quick response, I will use mannitol. Otherwise, I will just use hypertonic saline. Okay. What else you can do for this patient?
I would consider tranexamic acid for the
Why?
For the bleeding.
For the bleeding. The problem, I am not aware of any study that proved tranexamic acid beneficial in head injury or has improved the outcome. For sure, it is good in orthopedic trauma for major arteries, okay, injuries, but I'm not aware about it in head injury, so I cannot comment on it.
Okay, can I consider it in a ruptured aneurysm?
Intracranial, no.
Okay, thank you.
Okay, what else we can do for this patient?
Is it now the time for watch and see, maybe to monitor the patient now?
Well, within 6
If
hours,
he
we
is
probably
if he is
reassess.
responding to what we have given before.
Is there any place for surgery in this patient?
I think we prioritize the external ventricular drainage first before doing the craniotomy surgery.
Okay, where would you put your external ventricular drain? It's good to practice in severe head injury to put external ventricular drain because it will give you an idea about the intracranial pressure. Okay, but it has the risk of infection. You can use it as a therapeutic measure to reduce CSF within the ventricles. But in this patient, can you insert blindly an EVD in this small area of the ventricle? You can't. Unless you have a navigation, which is very unlikely to have it in a trauma patient. Okay, navigation CT scan, and then you have navigation machine. It's very unlikely that you can hit this with external ventricular drain. The external ventricular drain, بنسوي hole per hole في الفrontal bone, and we go blindly. We have measurement directions, and we slide that small tube inside the brain to hit this area of the ventricles. Unless the ventricle is dilated, you cannot really get an EVD in this patient. So what is the option now?
Now we should go for a craniotomy.
If the patient is not responding, صح? If the patient is not responding to all these measures, we may consider decompressive craniectomy, which is removal of all the bone from the frontal lobes and equalize the pressure inside the skull with the atmospheric pressure. طب انت فاتح what do you think about taking these shrapnels outside from the inside the branch?
I don't think I will do it because they are sterile. There's no risk of infection.
Definitely, you are right. Okay. And actually, if you try to take them out, you will cause more damage. You will cause more damage if you try to take these shrapnels out. Okay. We just clean the external wounds. If the patient is not going for a craniectomy, you just clean the external wounds and close them. If he's going, you just do it in theaters when you close the skin. There's nothing further that we can do for this patient. After if we do the decompressive craniotomy, these shrapnels will stay in for life, and this make this patient contraindication for MRI scan forever. Okay, that's good. Abdato.
I have a question about the pneumocephalus we have talked about in the beginning. When to deal with the pneumocephalus? I think it is a life-threatening condition. It is a risk for herniation.
Well,
So
actually, it is not. Pneumocephalus, we see it frequently. We see it a lot. Okay, and in most open depressed skull fracture or compound fracture of the skull with our skull base fracture, one of the evidence of skull base fracture sometimes is the presence of pneumocephalus. It does not increase, the air will not increase the pressure inside the skull much. This is one. The problem only when we have what we call tension pneumocephalus. And tension pneumocephalus usually happens after surgery, okay? Or when there's anterior skull base fractures. And what happens is a like valve-like mechanism. So the air comes in and it does not go out. It is trapped, okay? And it keeps accumulating until it causes raised intracranial pressure, which is common after we do olfactory groove meningiomas, tuberculum cili meningiomas, especially if we drill the skull base and we get it open into the nasal cavity. We see it a lot, but usually in a trauma patient, it's rarely a big problem. Rarely a big problem. So unless it is tension pneumocephalus, and you will see compression of both frontal lobe، لانه الهواء راح يتجمع، المريض راح يكون نايم، فالهواء راح يتجمع superiorly، صح؟ الهواء بيطلع لفوق دائما، فراح تشوف both frontal lobes compressed by the air، وبسموها فوجي ماونتن ساين، اللي هو جبل فوجي في اليابان، انه البرين تيشيو مضغوط وصاير مثل الجبل في الوسط هيك، والباقي اسود حواليه. and this is a rare thing. جاوبت سؤالك؟
Could we consider it as a sign of infection, of a gas
No.
producing bacterial
well,
infection?
well this has just happened، صح؟ يعني ما رح يصير في عندنا colonization وgas forming bacteria which causes the infection. Okay, later on if this does not، if بعد 5 أيام صورت المريض، بعد ما راحت اللي موجود هنا شفت إشي تاني موجود أو pneumococcal، yes it can be, but gas forming infection is also rare, it's not that common في الانتراكرانيالي. تمام؟ So
تمام.
الشغله الوحيده اللي هي للاسف زي ما حكينا انها هي موجوده او مش موجوده، وهذا السلايد اعتقد من المحاضره الماضيه، انه احنا ممكن نستخدم الاي سي مونيتورنج. في عندنا الانفيزيف اللي هم اي في دي، فايبر اوبتيك، مايكرو ترانسيوسرز، وسترين جيج، ونيوماتيك. وفي عندنا نون انفيزيف اللي بنستعمل ترانسكرينال دوبلر، تمبانوبلاستي، اوبتيك نيرف شوت، diameter. All these can tell us, but يعني in general لهلا this is بالدول الغربية this is a standard of care. Okay, there are indications for ICB monitor and it is a standard of care. Unfortunately لا في الأردن مش موجود بكثرة، وفي غزة مش موجود حتى، مش من الشغلات اللي طلبوها الشباب في غزة أصلا، which is أكيد مفهوم ليش. وهي الصورة من المحاضرة الماضية عن الأنواع بتاعت الاي سي بي مونيتورز. This is الشغلات اللي انتم جاوبتوها. elevate the head of 30 degrees، ما تضلك مسوي النيك كولر أو compression على النيك، straighten the head and neck to neutral position، remove ties circumferentially around the neck، treat fever، maintain normocapnia. Okay, initiate sedative drug and analgesic، review CT scan to look for possible new issues or reversible، increase sedative to decrease the CMRO2، drain CSF، check sodium، hypertonic saline mannitol, and repeat CT scan. And the last thing is decompressive craniectomy. Mannitol we talked about it وحكينا كيف بيشتغل المانيتول، نفس الشيء الهايبرتونيك سلاين. اوكي، بس هذا الفيديو. تفضلي.
عندي سؤال سريع على المانيتول. حكينا انه ايش مشكلته لما نعطي ريبيتد دوزز ويكون البلاد برين بارير انه بيرميبل؟ شو المشكلة؟ شو ممكن
permeable. هلا what happens، كل دوز بتعطيها انت a small percentage of the mannitol will accumulate في الانترستيشيال spaces، لانه البلاد برين بارير is not intact. اوكي، فراح يطلع مانيتول و cannot be digested في الانترستيشيال spaces، فعم بيطلع كل شوي، كل دوز بنعطيها عم بيطلع شوي من المانيتول تتراكم في الانترستيشيال سبيس. بعد اول 48 ساعه بتصير هاي الكميه significant الموجوده في الانترستيشيال سبيس. فلما انا اعطي المانيتول الجرعه بعد 48 او 72 ساعه، انيشيالي بطلع على الاي سي بي مونيتور بلاقي دروب بالانتراكرينيال بريشر، بس بعديها بنص ساعه لما يطلع المانيتول من الانترافاسكولار كومبارتمنت بشوف انه عم برجع. ليه؟ لانه في عندي مانيتول متجمع في الانترستيشال سبيسز، هذا راح يسوي لي ريفيرس او ريباوند افكت، راح يرجع يسحب الفلويد من الانترافاسكولار كومبارتمنت للانترستيشال سبيسز. واضحه ولا ارجع اعيدها؟
بس اخر
مش
اشي
واضحه. يعني احنا مش كل مره عم نعطي مانيتول، في جزء من هذا المانيتول سمول برسنتج عم يتراكم في الانترستيشال سبيس جوا البرين. اوكي، لانه البلاد برين بارير مش انتاج، عم نعطي مره بعد مره عم تزيد الكميه تاعت المانيتول اللي عم تتجمع في الانترستيشال سبيس. بعد فتره بصير انا اعطي المانيتول، لما اعطي جرعه عاليه في الانترافاسكولار كومبارتمنت بتنزل لي الانتركرينيال بريشر، بعدين هاي بصير لها ميتابوليزم ودايوريس، تطلع باليورين المانيتول. طيب انا ضل عندي مانيتول موجود في الانترستيشال سبيسز، راح يرجع يسحب لي الفلويد من الانترافاسكولار كومبارتمنت للانترستيشيال. وضحت؟ بنسميها ريباوند افكت. لا شكله صح. طيب انا راح احاول اعيدها. يمكن اكيد يعني انا مش عم
لا
بوصلك.
وصلت يسلموا. جد.
اكيد.
اه
طيب
كنت
ماشي.
أكتب نوت فسوري تأخرت
اسمها ريباوند افكت اوف مانيتول، يعني اذا بدك تدور عليها تقرايها. هذا واحد من مرضاي اللي اجى صباح يوم العيد آه، قبل سنتين او ثلاثه بعد الكورونا مباشره. كان هذا السي تي سكان الديكمبرسيف كرينيكتومي اللي سوينا له اياه. وهذا بس أنا حبيت افرجيكم كيف هذا السي تي اللي سويناه عشان نسوي له كرينيو بلاستي. على الكرينيو بلاستي سويناها بعد 6 اشهر. فهذا السي تي بنسميه 3 دي سي تي سكان، فيري ثين سلايسز زي ما انتم شايفين. بروح ل 3 دي برينتر بيطبعوا لنا قطعه من البيك اللي هو عباره عن احد انواع البلاستيك، بولي ايثر كيتون باختصار البيك. في ناس بيسووه ميتال ستينلس ستيل. البيك افضل لانه بيعطيش ارتفاكت. وبتجيك البليت جاهزه، you just open and put it back. We hate doing decompressive craniectomy لانه هذا المريض كان لاكي، كان عنده اكسترا ديورال هيماتوما سوبراتنتوريال وانفراتنتوريال بالبوستيرير فوسا زي ما شايفين. هون البوستيرير فوسا احنا فاتحينها كويس، وسوبرا تنتوريال. فعنده كان طبيعي نسوي له كومبايند كرانيكتومي. ولسوء حظه الدريلين في المستشفى في يوم عمليته بتعطلوا، وكان يوم العيد وصعب نجيب دريل. we had to take it by nibbler، يعني نكسر العظمة كلها، هي تكسير. بس he's fine. سبحان الله، يعني خلاص مكتوب له يعيش هذا كويس. ف this is how it looks. احنا بشكل عام كجراحين بنحبش الديكمبرسيف كرانيكتوميز لأنه once you open the skull the brain herniates outside the skull and it causes more damage. عشان هيك it is the last resolution، آخر حل بنفكر فيه هو decompressive craniectomy، لأنها برضه it is a harmful surgery. طيب شوف السلايد اللي بعده. هذا مريض عمره 22 سنة، كان ماشي على بايك. he's drunk و... والبايك قلبت فيه. اجانا على الطوارئ، وصل كان بيمشي، بعدين suddenly he became unconscious. لما فحصوه كان في عنده ال right pupil dilated and fixed. So what is the diagnosis؟ وليش هذا كان المريض يمشي بعدين صار deterioration؟ وليش عنده dilated pupil؟
According to the CT scan, this is epidural hematoma. He was walking because he had lucid interval.
Perfect. ممتاز. Can you define lucid interval لزملائك لو سمحت؟
Lucid interval is first the patient becomes acutely unconscious, then he regains consciousness for a small period of time. It's mask, the massive hemorrhage he has in his
Yes.
head.
صحيح. بعدين هلا الانيشال trauma will cause some kind of concussion, so he becomes unconscious. Then he regain his consciousness. He start to walk and talk with no problems. بعدين hematoma starts to get larger and larger. It causes elevated intracranial pressure. He become unconscious again. طب ليش عنده dilated the pupil؟
Because there's a pressure on the oculomotor on the right side.
صحيح. شو بنسميه هذا لما يكون في pressure؟
Ipsilateral.
بحاول افرجيك اياها بالضبط هون تقريبا، يعني مش واضحة كثير. افرجيك الكومبريشن اريا. خليني احرك السلايد. هون تقريبا اوبسيلاترال كومبريشن عوض.
On the oculomotor.
اون ذا اوكيلوموتور. طب صار كومبريشن على الاوكيلوموتور، ليش يصير عندك دايليتد بيوبل؟ ليش يتاثر الباراسمباثيك بس؟ احنا راح الباراسمباثيك اللي بيسوي مايوسيس او وبخلي البيوبل يصغر. ضل اللي شغال السمباثيك اللي بيسوي دايليتد بيوبل، صح؟
because
طب
they are
ليش تأثر؟
external. The position of the parasympathetic is external inside the nerve fiber,
اوكي كمل لي.
while the while
بس
the sympathetic while the sympathetic is internal. I think it's the opposite.
لا انت بلشت صح. It is true the parasympathetic is external. سؤالي للكل،
So
في
the
sympathetic.
compression starts from.
لا خليني بس اسال سؤالي عشان تعرفوا شو قصدي. في sympathetic plexus جوا البرين، من وين بتطلع السمباثيك بلكسس؟
brainstem.
لا،
There's nucleus.
paraspinal sympathetic plexus، صح؟ السمباثيك نيرف من الباراسباينال، ما بتيجي من جوا البرين زي ما بصير في الباراسمباثيك. فاذا بتتذكروا بالاناتومي السمباثيك بلكسس مثلا في السيرفايكال عندنا سوبيريور سيرفايكال جانجليون، في عندنا الميدل وعندنا الانفيريور. واذا بتتذكروا انتم دائما كطلاب طب بتتذكروا هاي المعلومه. البانكوست تيومر تسوي انفيجن للستيليت جانجليون اللي هو الانفيريور سيرفايكال جانجليون، وهذا بيسوي مايوسيس وانهيدروسيس. ليه؟
Corner
لانه بروح
sympathetic.
السمباثيك بضل الباراسمباثيك جاي من الانتراكرينيال، السمباثيك جاي من الاكستراكرينيال. فبسوي لما يروح السمباثيك بصير عندي مايوسيس. هنا اللي بصير العكس، احنا هنا راح الباراسمباثيك ضل السمباثيك عم بسوي ميدرياسيس او دايليتد بيوبل. مزبوط؟ ذكرتوا شيء زي هيك في الاناتومي؟
I think we in the anatomy lecture we talked about the nerve, the oculomotor nerve, regarding the fibers of the oculomotor nerve. So it's a mixed nerve. From the external side of the nerve, we have the fibers of the parasympathetic system, while the
صحيح.
sympathetic fibers are located internally inside the nerve. I
What is located internally is the motor fibers. The parasympathetic fibers joins بيجوا مع الكاروتيد، بعدين عند السوبيريور اوربيتال فيشر they join الاوكيلوموتر. انت اللي بتحكي عنه شيء ثاني اللي هو بيوبل سبيرنج ونون بيوبل سبيرنج اوكيلوموتر نيرف بالسي، صحيح؟ تذكر
yes,
شيء زي
yes,
هيك بالميديسن.
yes,
لما
yes.
يكون في عندك دايابيتيك نيوروباثي، لانه الفازو نيرفوزا بتكون جوا البلد فيزل فبصير فيها اسكيميا، بصير في عندك بيوبل سبيرنج اوكيلوموتر نيرف بالسي، بروح الموتور function of the nerve وبتضلها الباراسمباثيك، صح؟
Yes, that's right.
ماشي. typical confusion. هلا الانكل herniation نرجع لهون للصورة. This is an extradural hematoma أو epidural hematoma. طب ليش سموها؟ يعني كنا زمان نسميها اكسترا، بعدين حكوا لا لنصير نسميها epidural. في حد بيعرف ليش؟
Because كبوت ميدو succedoneum is extradural hematoma.
مظبوط. في كتير شغلات اكسترا ديورال برا الديورا. اوكي، بيروستيوم، في فراكتشر، في بون هيموريج، سبجيليال هيماتوما، كلهم هدول اكسترا ديورال. اوكي. فابيديورال لا، على سطح الديورا. فالنومنكليتشر مرات تشينجز مع الوقت لمصطلحات اصح. فابيديورال is the correct naming. Uncus is the medial part of the temporal lobe. Once it starts to move medially because of this direction of force, it will compress the oculomotor nerve. بعدين it will compress the midbrain أو cerebral peduncle. cerebral peduncle إيش فيها؟ corticospinal tract. لما يصير عندي compression على corticospinal tract راح يصير عندي contralateral hemiparesis أو hemiplegia. اذا كمل وضلوا في ضغط راح يصير في عندي كومبريشن على البوستيريور سيريبرال ارتري اللي بغطي الاوكسيبيتال لوب، وراح يصير فيه انفاركشن. في يعني عندي يمكن مريضين او ثلاثه we saved them من الاكستراديورال. they survived but they ended by having occipital infarction. اوكي، بسبب الكومبريشن. الاكستراديورال its management الريزلتس تاعتها ممتازه اذا ما كانتش associated with other injuries if managed quickly in a timely manner. يعني it means quickly and we are talking about minutes مش أكتر من هيك. ف if you manage this quickly, your patient will survive with a good outcome. If you don't do it quickly, your patient mostly will have a bad outcome. Okay, let's look again على ال MR على CT scan. ايش ملاحظين شيء ثاني؟
There's
when a
midline
right
shift.
there is a midline shift. There is a significant midline shift أكثر من 1 centimeter. This is the frontal horn of the left ventricle, وموst likely إنه ال frontal horn of the right ventricle is here. Okay, but it is obliterated and compressed. This is septum pellucidum, which should be on the midline. This is a midline. This is the falx. هذا الأبيض اللي هنا is the falx. If you see, if you measure it, it's more than 1 centimeter midline shift.
If it's more than 5 millimeter, I would consider it significant, right?
Yes. هلا this is something مهم نحكيه إنه دائما midline shift صحيح it is significant in the acute stage. بس هذا المريض لو عنده large temporofrontal tumor, he could have a midline shift of 1 centimeter, but he's conscious. He's walking around with no problems. فهذا كله له علاقة بالcompensatory mechanisms of the ICB. يعني كل ما كان slowly progressing disease, the brain can tolerate. في شيء اسمه elasticity of the brain. هلا بشبه لكم اياه بشغله. Elasticity of the brain والcompensatory mechanisms can compensate if it is a slowly growing lesion. ولكن إذا صار الإشي بسرعة it fails. Okay, and this is result in the shift. إذا في سفنجة ومليانة مي مغطسة مي، إذا ضربتها بسرعة كويس، أو you put a pressure slowly عليها شوي أني مرة بتطلع مي أكثر.
الضرب اللي بسرعة.
لا
slowly
شوي جربيها، اضربيها ضربة بتطلع مي، بس مش كل المي اللي فيها، بس ضلي اضغطي عليها شوي رح تصفى.
لا أنا خطر على بالي إنه خبطة كتير قوي.
this is إلى حد ما يعني كاس over simplification للconcept of elasticity of the brain. Okay, it is not this way، بس يعني عشان أوضحها شوي. فلما يكون في عندي ليجن كبير بنمو شوي بصير عندي ميد لاين شيفت، بس المريض ممكن كلينيكلي يكون فيري ويل لانه الاي سي بي مش مرتفع، بس مريض صار عنده acute injury acute bleed he will become unconscious حتى ب 0.5 سنتيمتر او 5 مليمتر ميد لاين شيفت. الشغله الثانيه اللي بدنا نشوفها البليدنج في هذا المريض من وين اجى، ايش السورس تاعه؟
Middle
it may
meningeal
be
artery.
the emissary veins, the bridging veins.
No, middle
لا
meningeal artery.
بالاكسترا ديورال هيماتومز it is usually the middle meningeal artery. It is usually the middle meningeal artery. خليني اطلع الصوره مره ثانيه ونشوف البون ويندو. بدي تنتبهوا للبون ويندو، شو رايكم فيها؟ طلعوا هون المنطقه هاي وهون. شو رايكم؟ شو في؟
Right temporal bone fracture.
right temporoparietal linear skull fracture.
Is it a fracture or a suture? I was confused first.
اوكي خليني ارجع لك عليها. طيب شايف الترانسلوسنسي هون؟ this translucency بدني انه this is a fracture not a suture. كمل معها طلع translucent. لو انها suture اذا تقارنها بالسوتشر اللي هون، شايف how hyper dense is it؟ This is another fracture one. This is another fracture. This is a fracture. It's not a suture. This is a suture here. This is a suture. This is a suture. تمام؟ طيب. To summarize, extradural hematomas can arise from injury to the middle meningeal artery, and this is the most common. Middle meningeal vein. Duploic veins لما يصير في عندي bone fracture أو من الvenous sinuses. In patients with extradural hematoma, 22 to 56 are comatose on admission or immediately before surgery. هاي الصورة still ما في فيلم، بس بدي إياكم تطلعوا على this sign here. شايفين السواد؟ This area which is hypodense in the middle of area which is hyperdense. This is what we call swirl sign, which means that there is active bleeding. This is a hyperacute area of blood inside a area of a clot. This is a clot, okay? The hyperdensity is a clot, but this area here signifies an active bleeding. And these patients with a swirl sign, their hematomas are expected to grow. So when we see it, we get more worried that this hematoma will expand. So, indications of surgery: if the hematoma maximal thickness is more than 15 millimeters, if the hematoma volume is more than 30 cc, if there is midline shift of more 5 millimeters, or if the hematoma is causing focal neurological deficit. واضحة الاكستراديورال هلا؟
واضحة.
واضحة. طيب. هلا this is an elderly patient who has a ischemic heart disease. He's on aspirin and clopidogrel for his ischemic heart disease. He fell down the stairs this morning. He was immediately comatose. He arrived to the emergency department with a GCS of 6. He was stabilized. He had a FAST, which was normal. He had a spine CT scan, which did not show any fractures of the spine, but his CT scan showed this. Who would like to describe this CT scan?
Is it the banana sign on the right side? Or the
What is
crescent
banana sign?
The
Crescent
crescent
sign.
We can talk both crescent or banana.
Okay, crescent sign. Crescent هلالي. banana أنا أول مرة بسمعها. كويس. But it's
And
okay.
in
Yeah,
the
it looks
epidural,
like a banana.
It looks more like subarachnoid hemorrhage, not epidural.
Is it? Not a, no, this is not a subarachnoid.
Then subdural.
subdural hematoma.
Crescent sign, we see it in subdural hematoma. That's right. But what is this? Here. عشان أسهلكم إياها. What is this?
Isn't
This
that the
is-
flax cerebri? Flax.
This is, yes, this is the falx about becoming a tentorium. مش انتم متذكرين يمكن حكينا عنه المرة الماضية انه المننجز بتسبريت the supratentorial من infratentorial عن طريق انها بتسوي شيء اسمه tentorium. So this blood is accumulated on the superior surface of the tent, of the tentorium. That it looks like if it is intracerebral hemorrhage, but it is actually an extension of the subdural hematoma. Okay? So what you are going to do for this patient?
Stabilization, as we discussed.
Stabilization. Is this a surgical patient?
Depending on the shift.
He has a massive shift.
Yeah.
More than 1.5 centimeter.
In some
More than 2 centimeters.
Yeah, in subdural, I guess in the kid case, it's more than 10 millimeter, right?
10 millimeter of thickness of the subdural, and I can tell you this is more than 1 millimeter or 10 millimeter in thickness.
This is an indication for surgery.
Yes, but this patient is on Plavix.
Can I give like fresh frozen plasma or prothrombin concentrate?
Will it make difference?
No, he needs platelets.
He needs platelets. Will it make difference? There is no antidote for Plavix and many of the new generation antiplatelets. Okay. So what we do with these patients, we give them everything we can. We give them fresh frozen plasma, they give them concentrate, and we give them platelets. And then we take them to the theater because this is a life-saving procedure. If you don't operate on this patient, he will die. So there is a risk that you will have uncontrolled bleeding during the surgery because of the Plavix. But the best chance for this patient to survive is doing a surgery. What kind of surgery you will do?
Hematoma evacuation.
Via craniotomy, or you will do a craniectomy?
Craniotomy.
Craniotomy. Why not craniectomy? This patient has elevated ICP and you are already in. Why not to just take the bone out?
What was the other one?
Craniectomy, to remove the decompressive craniectomy that we spoke about. انت داخل خلاص بسوي craniectomy او بسوي craniectomy. ليش انه بس اسوي craniectomy وبعدين بسوي له cranioplasty.
So there's high risk of bleeding, I guess. I don't know actually.
There is no true or
It's an
wrong
acute
answer.
condition.
This is very debatable, and there's lots of studies trying to justify what is the right and what is the wrong. Whether we should do craniotomy and just put the bone flap back, or we should do a craniectomy in subdural hematoma when they are large like this, because the brain will. We know that most of these patients will have a swollen brain after the surgery, or we should do a craniectomy from the beginning. And these ones, I'm in favor of doing a craniectomy to remove the skull. But there's no right or wrong. Every surgeon has different approach for these. Okay, you can do a craniotomy, you can do a craniectomy. Both are right. Do the craniotomy, do the craniectomy, open the dura, evacuate the subdural hematoma, control the source of the bleeding, and then close it. Okay, whether you put the bone back or not, it is up to you, and it depends how much swelling you get from the brain. So if the brain is swollen, I will not put the bone back, okay? Because this will cause elevated intracranial pressure. If the brain is not swollen, I will put the bone back. So it depends what is happening during the surgery, okay?
Do we wait for the clots until they dissolve and then we move for the craniotomy?
If this patient, what you are saying is true, okay, but not in this patient. Sometimes we get a patient with Glasgow coma 13, 14, have a minor neurological deficit. He's on aspirin or warfarin or Plavix. We wait for 1 week to 2 weeks. We give them dexamethasone because to prevent formation of new membranes around the hematomas. Then what happens to this clot? شو بصير في أي كلوت في الدنيا مع الوقت؟
It dissolves.
It liquefies, بتصير سائل, بعدين it gets absorbed, صح؟ So what happens to this clot? It becomes fluid with time. After 3 weeks, it becomes fluid. So instead of doing a craniotomy, which is a high-risk procedure and very stressful to the body, we do bare holes and we drain the fluid. We do 2 bare holes, like نسوي bare hole هنا مثلا وبare hole هنا. مجرد ما انت فتحت 2 bare holes, all this hematoma will drain from the posterior bare hole, صح? Then you will irrigate with warm saline, okay, as much as you can to evacuate more and more of the hematoma. So this becomes, instead of treating it as acute, you treat it as a chronic subdural hematoma. You wait until it becomes liquefied and you treat it as a chronic subdural hematoma instead of acute traumatic subdural hematoma. But what you said is right. Whoever said it, it's right. So subdural hematomas, the blood is hyperacute within 24 hours. Then it becomes acute, and this is hyperdense on the CT scan within 48 to 72 hours. Within 3 to 20 days, it's become isodense to the brain, and this is what we call subacute. After 3 weeks, it becomes dark on a CT scan, and this is when the hematoma has liquefied and become fluidy. Okay, and you can take it out with bare holes. Sometimes even the subacute, we do it with bare holes instead of craniotomy in high-risk patients. Again, you remember the bridging veins from the previous lecture. ليش في عنا bridging veins؟ مين بتذكر؟ ليش
They
اسمهم
drain
bridging
the
veins؟
CSF into the inferior vena cava through the thing.
علي صوتك شوي مرة ثانية.
They drain the CSF and
هذاك الاركنويد فيلاي، هذول bridging veins.
To drain blood into the sinuses.
Into the sinuses. نتذكر من اللي حكيناه المرة الماضية انه البلاد فيزلز سواء الفينز او الارتريز موجودين وين؟ موجودين في السب اراكنويد سبيسز تحت الاراكنويد لاير. والساينس عبارة عن two leaflets of the dura. From the right and the left, they combine and make the superior sagittal sinus, and then they descend down to make the falx cerebri. The bridging vein لازم يخترق الأراكنويد عشان يدخل على الديورا، على السوبيريور sagittal sinus. فبالتالي بتعملي صار two point of fixation، يعني صار مربوط في مكانين. الأول هو مكان ما بيطلع من الأراكنويد، والثاني محل ما بدخل على superior sagittal sinus. هلا with age we get brain atrophy، فهدول بصفوا bridging veins معلقين في السي اس اف. فأي rotational movement can cause them to rupture and cause a gradual bleed, and this what ends with chronic subdural hematoma. وفي حالات التروما برضه they are liable انه يصير فيهم rupture و hemorrhage. واضح ليش اسمهم bridging vein؟ لانهم they bridge from the arachnoid to the sinuses, and this caused them to have two point of fixation، يعني مثبتين من منطقتين. فأي حركة غلط أو أي rotation للبرين can cause them to rupture. واضحة هاي؟
So the subdural hematoma have a worse prognosis than the epidural.
Definitely,
Say it like that.
definitely, because the blood is on the in contact with the surface of the brain. Okay, and this حتى the risk of epilepsy is higher. كويس. Extradural hematoma, it is separated from the brain by a tough layer which is the dura. بالسبديورال الريسك اوف ابيليبسي، الريسك اوف برين دامج. وهلا جايين لسلايد بحكي لك السورس اوف بليدنج في السبديورال. it could be an cortical artery او cortical vein، وهذا معناته صار في دمج عندي في الاريا سبلايد باي هذا الارتري او vein. هذا هو السلايد بحكي عنه. 12% to 29% of patients admitted with severe traumatic brain injury will have acute subdural hematoma. Mortality rate ranges between 40 to 60%. Acute subdural hematomas can result from bridging vein injury, cortical artery, cortical vein, أو venous sinuses, and this is usually disastrous. يعني الحمد لله مرتين تعرضت للموقف معهم إنه يكون bleeding من الفينس sinus. we dealt with it, but it is massive bleeding اللي بصير. indication for surgery إذا كان الهيماتوما thickness أكثر من 3 ملم، هيماتوما فوليوم أكثر من 30 سي سي، هم تقريبا نفسهم بس الثيكنس بصير أقل، أو focal neurological deficit caused by the hematoma. لا، السلايد اللي قبله. Who can describe? This is an image. It is not a movie. It's not a movie. Okay, or a playback. What you can see on this CT scan.
There's fluid in the sinus, in the tillus and gyruses. It looks like subarachnoid hemorrhage.
This is it's not a fluid. We don't like you saying fluid, there's a hyperdensity in the sulci and the gyri. And this hyperdensity is most likely blood, and this is in the subarachnoid spaces. The most common type of hemorrhage in traumatic brain injury is subarachnoid hemorrhage. The most common cause of subarachnoid hemorrhage is traumatic brain injury. اوكي اتس نوت انيوريزمال لانه في شغلتين بيسووا subarachnoid hemorrhage تروما والانيوريزمز واخر واحده الاي في امز. The most common cause of the subarachnoid hemorrhage is trauma. The most common bleeding type of bleeding يعني مقارنه بالاكستراديورال subdural بالcontusions it is subarachnoid hemorrhage. حتى minor velocity trauma can cause some subarachnoid hemorrhage. Who would like to describe this CT scan before I give you the history?
Can you move it
مرة
again?
it's coming, man.
On the left side, we have parenchymal hyperdensity.
Parenchymal intraaxial hyperdensity on the left-hand side. Yes, what else? Surrounded by
Hypodensity.
a hypodensity. And there's also a hypodensity on the right temporal lobe. Is that right?
Yes.
What else? There's a small bleed here, which may represent acute subdural. If you see these sulci and gyri here, they have also subarachnoid hemorrhage.
There is calcification in the choroid plexus.
hello. I'm sorry للأسف عندي disconnection من عندي الإنترنت. Carla, I think just one more slide and we will finish. سامعيني ولا في مشكلة بالصوت والسكرين شيرنج؟ ألو؟
Yes, we can hear you.
You can hear me. Okay. So these are what we call contusions within the brain, and there's no actual surgical treatment for contusions. We treat them if they cause elevated intracranial pressure by all the measures that we discussed in the first case. So we don't go and try and take this out because some of the tissue within these are still, or surrounding these is still functioning. A surgery will destroy these functioning areas or penumbras. And if you look at this, this is what we call coup and counter coup. So once there's a trauma on this direction, it may cause hemorrhage or contusion in the contralateral side. And this is a typical example for this. The impact is from here. The brain moves away from the direction of the trauma, and then it moves again to the other direction, and this will cause damage to the brain tissue, and this will result in contusions. These are nasty for causing seizures. Okay. في موضوعين ضلوا اللي هم concussion, diffuse axonal injury و skull base fractures. انا هدول يعني I leave it to you تقرأوا الديفينيشنز تاعتهم و we will stop here. مين عنده أي سؤال؟ شكرا يا عمر. ابعت لكم، راح ابعت البرزنتيشن لكارلا وهي she will pass it to you guys. Okay.